Our next speaker is Paul Sundell from the University of Wisconsin. Paul is a pediatrician and immunologist, and we think that he's related to our family. I don't know, maybe I just like to claim people who are so bright and successful, but one of these days we'll figure it out. Paul?
Thanks, Cousin Bruce. It really is a real privilege to be here, and I thank Bruce so much for inviting me to come from Madison for this meeting. And I feel very fortunate to have the chance to be speaking after the last two speakers, both Ken and Jeff. I think they were remarkable talks. They remind me first of words one of my mentors always said, and that is, for those of us working in cancer research, research has a human face. This was Paul Carbone. Secondly, I think that the previous two talks emphasize that in order to make progress, you need to have passion, you need to have energy, you need to have support, you need to have good ideas, you also need facts. So I'm going to take a turn at trying to show where we've tried to make progress in the area of immunotherapy. And I'd like to pick up on some of the points that Ken Anderson made earlier, that there are a variety of ways that immunotherapy is having an impact in a few diseases. This has actually been an outstanding year for cancer immunotherapy. This summer, there were 3 separate New England Journal articles representing large multi-institution trials showing real efficacy in prostate cancer, in melanoma, and in neuroblastoma. I've had the opportunity to be involved in that neuroblastoma work and would like to talk about immunotherapy of neuroblastoma. Neuroblastoma is a rare disease. We're interested in treating children with high-risk neuroblastoma. There are 300 of these children diagnosed annually in the United States. Even though it's rare, as you heard, rare cancers are important, and amongst pediatric cancers, this is one of those cancers where we've not done as good a job as we have with the more common childhood cancers like childhood leukemia, where our cure rates are pushing 85% cure rates. For neuroblastoma, high-risk disease, the best therapy available involves multi-agent chemotherapy along with local radiation therapy, surgery, ablative chemotherapy followed by an autologous transplant, and cisretinoic acid. And that very exhausting one-year regimen is providing cures for only about 40% of these children. Clearly, we have to do better. The approach that we're interested in involves the immune system. And if one had a monoclonal antibody that could recognize a tumor, there are a number of ways that antibody might mediate some anti-tumor effects. The effector components of an antibody involve activating complement, molecular destruction through membrane holes, or antibody-dependent cell-mediated cytotoxicity by effector cells of the immune system, particularly natural killer cells, macrophages, and neutrophils that all have different Fc receptors that allow them to recognize and bind to the tumor and then kill it. So in the late 1980s, we had been doing some work with IL-2, and we're somewhat disappointed that IL-2 was not causing as great a T-cell-mediated anti-tumor effect as our mouse models had suggested. We were showing that giving IL-2 caused a massive expansion of natural killer cells in patients, and I had never been interested before in natural killer cells, but we figured, how could we make some lemonade out of this? And became interested in natural killer cells because they could mediate this ADCC reaction. I had the good fortune to be at a study section sitting next to Ralph Reisfeld, who was making a monoclonal antibody that recognized a disialloganglioside overexpressed on neuroblastoma and on melanoma. We put our heads together and thought it would make sense to try and combine these approaches, and Jackie Hank in our laboratory took blood from healthy volunteers, asked them to kill neuroblastoma cells in vitro, and you can see that we got a little bit of killing when we tested the cells outright, but when we added IL-2 or antibody, or both IL-2 and antibody together, we did much better. Now, if we took blood from patients with cancer, we didn't do nearly as well. Here's 2 patients with cancer. These 2 patients happened to have kidney cancer. They were referred to our center to get IL-2, and this blood was taken from them after they had had their surgery to remove their primary tumors, but no other treatment. And the point of this is that cancer itself is very immunosuppressive. These patients had very poor natural killer cell function, but they were referred to us to get IL-2, and so when we gave them roughly 3 weeks of IL-2 in vivo and then took blood from them, we now showed dramatic killing of the neuroblastoma in vitro, as long as we had both the antibody and the IL-2 present. This suggested to us that we should come up with an in vivo regimen that tried to do that same thing. So we proposed that we would give IL-2 using that same moderate dose regimen that we had been developing in Madison for several weeks, and at a time when we knew the natural killer cells were activated, start giving monoclonal antibody to try and get ADCC in vivo. We began working on this in 2 diseases, both in melanoma, local studies done in Madison, and in neuroblastoma, studies being done through the Children's Oncology Group. And over the next decade, we did a series of phase 1 and pilot and phase 2 studies. We learned a lot about the pharmacokinetics and pharmacodynamics and half-lives and biological effects in the serum, and it was all very interesting. But the bottom line is patients weren't getting better. And our mouse data provided a number of reasons why using these approaches would not make a big difference for patients with bulky disease. Without going through the data, we concluded that in order for this approach to be effective, we'd really want to use it for patients with minimal disease, namely patients that are at high risk for recurrence, but that have been put already into remission. Now, in order to put all of our ducks in a row, we wanted to use not only IL-2 to activate the natural killer cells to mediate ADCC, but we know that in order to activate macrophages or neutrophils to mediate ADCC, a separate growth factor, namely GM-CSF, can potentiate their activity. So we worked on a regimen that would allow us to give IL-2 and GM-CSF to the same patients using a sequential approach. And then we put that together in a regimen to give to patients with neuroblastoma when they were in remission. So the pilot studies that were done through the Children's Oncology Group took those children with high-risk disease that had gotten all of that former therapy, had finished their autologous bone marrow transplant, were in remission but at very high risk for recurrence, and we gave them a regimen of this chimeric anti-GD2 antibody alternating GM-CSF or IL-2 for several months. And the results of this pilot study on only 25 patients looked pretty intriguing. 75% of the children were still alive at 2 years, but many of them had recurrent disease. The data looked like they might be better to historical controls, but that wasn't going to convince anybody. It took a fair amount of work to convince our clinical colleagues in the Children's Oncology Group that this was the most important question we could ask in North America for neuroblastoma. We worked from 1998 to 2002 to get this study up and approved, and this study, which was chaired by Alice Yu, tested that regimen that I just mentioned. Children with high-risk neuroblastoma got all of their upfront therapy, and after they finished their autologous stem cell transplant, they were randomized to the standard maintenance agent, retinoic acid, or to retinoic acid plus this immunotherapy cocktail. Our statisticians said that it would take us until 2012 to address this question to get enough patients accrued. We'd need 386 randomized patients. Many families of children that had this disease chose not to participate in the study. Intriguingly, half of the parents who chose not to participate said they didn't want to participate because they knew antibody was best and they wanted to go to a place where they could get it. The other half who chose not to participate said they didn't want the toxicity of the antibody and the immunotherapy, and they didn't want to enter a trial where their child was at risk for that. So that's why you got to do a clinical trial. So we expected the study to end in 2012, and in February of 2009, our statisticians told us that they had to unblind the data because there was a result that was significant, and it was this result. The children that were getting the immunotherapy were clearly doing better than the ones that weren't. At the 2-year time point, the disease-free survival difference was 46 versus 66%. It was very significant. And as you can see, it looks like the curves are plateauing. In this disease, relapses don't normally occur late. So we think this is translating to an overall cure rate for this disease of 60%. As soon as we saw these data that were obtained with only 60% of the study being completed based on our anticipated accrual needs, we of course closed this treatment arm and told all COG institutions that this was now the standard therapy for neuroblastoma. And we like to think of that day when that decision was made as the day that we increased the cure rate for neuroblastoma from roughly 40% to 60%. So it's a small step, but it's clearly a step in the right direction. The bad news is that we still have 60% of these children having recurrent disease and dying. We need to do better. So the bottom line messages from this study are, first, in the setting of neuroblastoma, this immunotherapy is now the standard treatment. We think that it was based on our preclinical rationale for adding the antibody and the cytokines together. Interestingly, a large study was published in 2004 from German investigators using this same antibody in children with neuroblastoma in remission, and the last sentence of their manuscript was that this same antibody is not going to be used anymore in Germany because it wasn't effective. Now, what was the difference between their trial and ours? There were several, but the one that we think is the most important is they used the antibody by itself. We use the antibody with the effector cell activating cytokines to augment ADCC. That's not proof that that's what made the difference, but we think it probably is. For other diseases, neuroblastoma is very rare, but we're using an antibody that mediates ADCC. There are a variety of antibodies being used that mediate ADCC for far more common diseases. Rituxan, Herceptin, Erbitux, all likely work, at least in part, through ADCC. None of these antibodies has yet been tested in the minimal residual disease setting in the presence of cytokines that activate effector cells to mediate ADCC. We suggest that in these diseases it might be appropriate to consider a trial design that would activate effectors at the same time as one's using the antibody, using agents like IL-2 or GM-CSF or lenalidomide, as Ken Anderson had mentioned. So how are we going to do better for the 40% of children that are relapsing? This is a genetically engineered next generation of that anti-GD2 antibody. It's a humanized antibody made by Steve Gillies and Ralph Reisfeld. It's 98% human amino acid sequence. It recognizes the GD2 antigen on the neuroblastoma, but it's linked to IL-2 at the carboxy terminus of each immunoglobulin heavy chain. And at least the design of this was such that the IL-2 on the antibody would allow this antibody to not only mediate ADCC through the FC receptors, but it could bridge effector cells to the targets and activate them through IL-2 receptors. And we've got some preclinical data that shows that that's the case. In vivo, this fusion protein works far better than antibody and IL-2 as separate agents. Each of these bars represents the number of neuroblastoma metastases in a mouse model. If you treat these animals with saline and then sacrifice them after a month, they've all got a large number of metastases. If you treat these animals starting on day 1 after the tumor was injected with antibody and IL-2, you decrease the number and the size of the metastases. This is the equivalent of the protocol that we tested in the phase 3 setting. This is the same molar amount of antibody and IL-2, but now is this fusion protein, and there's no cancer detected in these animals. Based on that, we got this agent approved for the IND for the first in human testing in both neuroblastoma and in melanoma. That last slide, though, we don't think is a very clinically relevant mouse model. In order to try and make it a bit more relevant, we took mice and injected them with neuroblastoma. And rather than treating them just one day after the neuroblastoma went in, we gave groups of mice this same treatment with the antibody linked to IL-2, and we sacrificed all the mice after a month to look at the number of their metastases. The difference between these groups is when we started the treatment. And as you see, if you start the treatment early on day 5, you do much better than day 7 or day 9. We think these data are further evidence to say these kinds of immune therapies are likely going to be working to prevent recurrence in the setting of microscopic disease. So why is it that the IL-2 linked to the antibody works so much better in vivo than the same amount of IL-2 and antibody in the same syringe, but as separate molecules? I'd like to show a little bit of preclinical data regarding this. In order to do this work, we've used the antibody linked to IL-2 that recognizes the GD2 on neuroblastoma and melanoma, the agent I've shown in clinical trials. We've also, in this preclinical work, used another agent made by Steve Gillies. It's an antibody that recognizes the epithelial cell adhesion molecule present on a variety of epithelial cancers. It's also linked to IL-2. This molecule is also in clinical trials. First, if you take natural killer cells and fluorescently label them and then ask them to stick to a monolayer of ovarian cancer cells, you can see that they stick much better if you treat the tumor cells with the antibody linked to IL-2 as opposed to the antibody by itself. In addition, if you treat with this antibody linked to IL-2 and then block the IL-2 receptors with an anti-IL-2 receptor antibody, you block the natural killer cells from binding, proving that this antibody linked to IL-2 is binding NK cells to the tumor through their IL-2 receptors. These are studies looking at the synapses that are forming between natural killer cells and tumor cells, and when an immune cell recognizes something it's interested in, its effector molecules polarize towards that target. And what Dr. Goebbels in Manish Patinkar's lab did was look at the fraction of synapses that show polarization of LFA1 or CD2, and you can see this antibody linked to IL-2 shows much more polarization than the naked antibody or naked antibody plus IL-2. The same thing happens when we look at natural killer cells from patients with ovarian cancer. This is peripheral blood. The same thing has been seen with cells from their peritoneum. Next, we could look at the actual conjugates that form by flow cytometry. So if you look at this panel here, what we see is that the melanoma cells here are stained red. The natural killer cells are stained green. And when the natural killer cells bind to the melanoma cells, you get a two-color signal. So if you put these killer cells together with the tumor in the presence of this fusion protein, we get a good number of conjugates. If you block that receptor with the anti-IL-2 receptor antibody, you don't get conjugates. If you use IL-2 alone or antibody alone or antibody plus IL-2 combined, but not as a fusion protein, you don't get the conjugates. So clearly having the IL-2 receptor on is important. Here's a picture of what we get when we let a natural killer cell bind to tumor cell. This is actually two natural killer cells, and we've used this antibody linked to IL-2 in this setting, but we've labeled it fluorescently so that it stains green itself. So the green color here is this antibody linked to IL-2. If we would have labeled the natural killer cells before the synapse formed, the cells would be green because of the IL-2 receptors all around the natural killer cell. But when the synapses form, all of this fusion protein now goes to the synapse where the antibody is allowing the natural killer cell to recognize this tumor. Schematically, what that means is if you label the tumor cell with this antibody, through the FABNs of the antibody, the fluorescinated fusion protein binds to the tumor. If you bind the fluorescinated fusion protein to the natural killer cell, it binds through the IL-2 receptors. But when a synapse forms, all of this fusion protein on the natural killer cell is moving towards the tumor cell. Up till this time, I don't think anybody has shown that IL-2 receptors can function in this way. And the difference is the IL-2 receptors are here seeing not soluble IL-2, but cell membrane-bound IL-2. Here's additional proof of it. We allowed tumor cells to synapse with a natural killer cell in the presence of this fusion protein, then fixed the cells, and then stained with an anti-IL-2 receptor antibody. So what's green here are the IL-2 receptors. And this shows when the synapse formed, all the IL-2 receptors went to this synapse. The consequences of that are that the natural killer cells can kill tumor cells far better using this fusion protein than using a naked antibody. Here's an example of this. The effector cells we're using here are the NKL line we obtained from Jerry Ritz here in Boston. This leukemia cell line is a natural killer line that has IL-2 receptors. When we add the fusion protein, the immunocytokine, we get far better killing than when we add the antibody either alone or together with IL-2, as long as we're testing on a tumor cell that has the right target, GD2. This tumor cell does not have GD2, and so adding that fusion protein doesn't help anymore. So schematically, we think the fusion protein is allowing us to mediate ADCC in three separate ways. First, we've got conventional antibody-dependent cell-mediated killing mediated through FC receptors. That's the standard approach. Second, we think that there are some natural killer cells that might not cross the threshold to mediate killing through the FC receptors alone. But if they're seeing IL-2 stuck to this tumor cell, the IL-2 receptor activation is providing these cells an additional stimulatory signal that now lets them cross the threshold and mediate killing. And finally, we have data that I don't have time to show that suggests even in the absence of FC receptors, because IL-2 is linked to this antibody, the IL-2 receptors themselves enable enough of a synapse to form to mediate ADCC. So these are in vitro data that help provide some possible explanation for why we're seeing such better in vivo effects of this fusion protein than the naked antibody. I'm going to skip these next slides, which talk about where the fusion protein goes when it binds to a tumor cell or a natural killer cell, and instead just finished with some clinical data. So I've pointed out that we think these approaches will work best in the setting of minimal residual disease. But it's hard to develop cancer drugs in that setting because the normal phase 1, phase 2 approach requires in the phase 2 setting you've got something you can measure for a response. So patients with relapsed neuroblastoma that have failed all of the upfront therapy that I mentioned before have a terrible prognosis. These patients can relapse, though, in 2 separate clinical settings. They can relapse with bulky disease that's seen by CT scan or MRI, and those are patients that we call stratum 1 patients. But they can also relapse with less evident disease you can't see by CT or MRI, but that you can see with a very sensitive nuclear medicine scan, MIBG I-123 scan, or by doing bone marrow aspirate and looking at tumor cells within the bone marrow. Those patients still have quite a bit of disease, probably 10 to the 9th or 10th tumor cells in their body, don't have enough to see by CT scan or MRI. We call those stratum 2 patients. So we did our phase 2 trial of this antibody linked to IL-2 with these relapsed neuroblastoma patients. 38 patients put into the study. 5 of the patients had complete responses. 1 still in complete response now over 3 years. In addition, we had 2 patients show very striking mixed responses, significant or consistent with clinical benefit. So if you look at where these patients that had some activity came from, the study enrolled 13 patients in stratum 1 with bulky disease, and none of those 13 patients were in the group that showed any benefit. But of the 24 patients that were in stratum 2, that's where we had the 5 with complete response and 2 with clear improvement. When you do the t-test to say is stratum 1 different than stratum 2, it's significant, even though the study wasn't designed or powered to test that. We think this is consistent with our preclinical data. The last point that I want to mention gets back to the issue of personalized medicine. We've talked up till now, not only in this talk but in several others, as to how we need to understand the tumor that we're targeting, what antigens are on its surface, what genes are activated in the tumor, and that's very important in predicting which drugs to use. I'd like to present a separate concept, and that's personalized medicine looking at the host or the soil the tumor is growing in. And the genes that we're interested in for this are killer inhibitory receptor genes, genes that influence the way one's natural killer cells work, and also your FC receptor genes, genes that influence the way your FC receptors mediate ADCC. I'll only have time to go through the KIR example. So, all natural killer cells have activating receptors and inhibiting receptors. And in this simplistic diagram, if you have an activating receptor that sees an appropriate ligand and an inhibitory receptor that sees its appropriate inhibitory ligand, these two cancel out, and this natural killer cell will not mediate killing. Alternatively, if your natural killer cell has a activating receptor that sees the activating ligand and its inhibitory receptor is not seeing an inhibitory ligand, the activation will win out and the tumor cell will be killed. Now, this is a very important phenomenon that in the last decade has been proven to be critical in the way natural killer cells are preventing leukemia from relapsing in the setting of haploidentical bone marrow transplants. But more intriguing, over the last 2 years, it's clear that if you look at any of our own genotypes, we can be genotyped for our KIR genes, and we can be genotyped for our own KIR ligands, our HLA molecules, and roughly 60% of the population have inherited at least one KIR gene for which they don't have an HLA molecule to turn it off, while 40% of the population has inherited an inhibitory ligand for every one of their KIR genes. Saying that differently, it means 60% of us are KIR mismatched for our own ligands, and 40% are KIR matched. This has been shown to have some importance in the setting of bone marrow transplant. These are data from Sloan Kettering showing that if you look at the bone marrow transplant success following transplants for neuroblastoma at that center, those individuals that were mismatched for their own KIR ligands did better than those that are matched, implying that some component of NK biology might be influencing the result of this bone marrow transplant. We saw those data and figured if this is being done through NK cells, and our fusion protein works through NK cells, that these KIR ligand relationships may be important in our immune response using this antibody linked to IL-2. So we took the data from that phase 2 study where we had 7 patients show either complete response or benefit, and we looked at the genotypes for the ligands and the receptors for all of those patients. And if you look at the individuals that improved, either the CR or the improvement, 7 out of 7 were in the KIR mismatch group. This had a p-value of 0.03. Even though it's a very small study, it says that because this therapy is designed to work through natural killer cells, it looks like maximizing your natural killer cells' ability to be turned on through this activation mechanism may be important. So what's the clinical corollary to this? If we first confirm this in this setting, it might suggest that as this kind of approach moves ahead, for those people that we know are KIR mismatched, it makes sense to use this approach. For those that are KIR matched, the ones that we think don't have a chance of benefiting in this setting, maybe we need to do something more. There's antibodies that could block their KIR ligands from inhibiting, or we could think of giving them allogeneic NK cells that might have the appropriate KIR mismatch setting. Now, before moving in that direction clinically, of course, we need to confirm this result and also determine whether this result in a phase 2 setting will show up in a phase 3 setting for patients that really have minimal disease. Maybe even if you're KIR mismatched, maybe you'll have enough NK function to get rid of microscopic disease when you weren't able to get rid of macroscopic disease. So we've done a couple other similar kinds of analyses that because of the time I won't go through, but just to say that as we're thinking about genotyping and looking at best cancer therapies to personalize treatment, we need to think not only about the tumor, but about the host as well. So in summary, with respect to the kind of immunotherapy that we're working on, we're eager to use these approaches that we think can be exported to large clinical testing or clinical application. These immunotherapies all can go into a vial of a drug, can be stored in a pharmacy and given in a standard clinic or inpatient unit. And we think that the place to be using these kinds of approaches are patients that are in remission and at very high risk for recurrence, and we're focusing our testing on trying to develop these in that setting. So with that, I'd like to thank the many people that have been involved in this work. I tried to mention several of them as I was presenting the work. Clearly, the individuals from our laboratory and research center in Madison, also many pediatric oncologists. I should have pointed out that this phase 3 result that we've got in neuroblastoma was just published last month in the New England Journal of Medicine, and Alice, you was the leader of that clinical trial, but many pediatric oncologists from around the country were involved and required to make this happen. Thanks very much.
Paul, thank you for this terrific presentation. I'm sure there are questions. Henry?
Suppressor cells. Cyclophosphamide will do that for you. And I wonder whether now, particularly that suppressor cells are getting involved also in the NK function, whether you have tried that to augment the effects of your IL-2 antibody.
So in our preclinical models, yes, we've done that, and we've shown that if we give chemotherapy, including cyclophosphamide, depending on how we time it, we can get an augmented immunotherapeutic effect. In our clinical work, we really have to walk before we can run, and we're going one step at a time. In that large phase 3 trial, the immunotherapy regimen that we're using does not include any cyclophosphamide in it. It's the antibody and the IL-2 and the GM-CSF. But the setting that we chose to use it is in patients who are just recovering from their autologous bone marrow transplant. We require that the patients start this immunotherapy between day 56 and day 100. And that's at a time when we have evidence that their natural killer cells are coming back, but their T cells and likely their T suppressor cells might still be inhibited by all of the previous chemotherapy.
Paul, maybe I'll ask a question, a practical question. Do you have a corporate sponsor for the antibodies?
It's a terrific question, and it brings together the partnership question. This is a rare disease. I mentioned only 300 children a year diagnosed with this disorder. We're hoping that this agent may prove to be useful in melanoma, a more common disease. But in order to do this work, this neuroblastoma work and our current melanoma work has required a partnership, but it's been a partnership between academia and the NCI. As much as the antibody was made by Steve Gillies, no company has wanted to, until recently, pick up the rights to develop it. And in order for us to do any of this work, we needed not only the COG support to do the clinical trials, we needed the NCI's support to pay for the research, but we also used the NCI Frederick facility to make the clinical grade antibody for us to be able to do both the clinical trials of the chimeric antibody as well as the clinical trials of the humanized antibody IL-2 fusion protein. Now that the phase 3 results have been published, a company, United Therapeutics, has stepped forward with NCI's help and is taking over the licensing of this drug, and a validation safety study is now being done through COG to get this drug licensed through the FDA.
What about the fusion?
So the fusion antibody does have a corporate partner that has been providing us recently the agent for our next clinical trials. For a while, they weren't as excited about the work we were generating and said they'd allow us to use the agent, but we had to figure out how to pay for it and how to get it made. And so we were lucky the NCI Frederick facility was there, and they were able to be convinced to make this drug for our clinical trials. Based on the phase 2 results I showed, the company that has developing rights to this antibody is more interested in it, and that's why they've decided to make many grams of it for our next trials.
Congratulations, John. Value of the Frederick facility. So, what about melanoma? Is there interest in, the field is getting a little crowded now. We have ipilimumab and we have the BRAF inhibitors. It doesn't mean that we don't need more. Clearly people are, but you mentioned that the antibodies are going to be most effective in patients who are in remission or have low burden disease, and we do achieve that with these drugs.
We can achieve remission in melanoma. The difference, though, in melanoma from neuroblastoma is we don't have a target that we can look at to actually see in those patients in remission, are we having an actual anti-tumor effect? The science of looking at circulating tumor cells is moving ahead, but I don't think anybody yet believes or has proof that that's a valid target to make a clinical decision based on. So we don't have the equivalent of the bone marrow aspirates where we can actually look at under the microscope and really see tumor cells in neuroblastoma patients. To try and address this, we now have a trial open in Madison that's being led by Mark Albertini for patients that have had relapsed metastatic melanoma, but melanoma that can be put back into complete remission surgically. These patients are being referred to our team. We're giving them a course of this agent before their surgery, resecting the melanoma, looking at it in the laboratory by a variety of parameters, and then continuing on with 2 more courses of this therapy. The study's ongoing. It'll be a small study, but we're hoping that it provides enough information to convince one of the cooperative groups to do this in a larger way.
Any other questions for Paul? I hope, well, there's one in the back, yeah.
Paul, I'm very interested. I'm wondering, obviously, IL-2 is a very short half-life, and I'm wondering whether the fusion antibody has a much shorter half-life than a regular antibody.
It's a great question, and we were a little surprised when we did the work both in mice and in patients. The half-life of IL-2 is roughly 45 minutes, depending upon which half-life you're looking at. The half-life of these antibodies is about 3 days. When we link the IL-2 to the antibodies, the half-life is 4 hours. So it's interesting that when you compare the antibody linked to IL-2 against antibody and IL-2 head-to-head, the area under the curve for the fusion protein is much shorter, even in the mice, but the anti-tumor effect is far greater.
So would a further approach perhaps be to defucosylate the antibody so you can really drive the ADCC, perhaps independent of the IL-2?
It's a great approach. It's actually being done now for the chimeric antibody. The naked antibody not linked to IL-2 has been humanized, and it has been defucosylated, and studies of that agent are going on now at St. Jude. At this point, the fusion protein has not been defucosylated. We think that would be a good idea, but we also think that because there's IL-2 on the end of the antibody, the interaction with the Fc receptor might not need to be as high affinity. So we're not sure if we have to defucosylate it.